Claudia. Hi, Morgan.
Hi, everybody. Good evening, everyone. Welcome to a very special interactive webinar. My name is Morgan White. I'm the marketing manager here at IVFMD. Tonight, we will be discussing fertility preservation options with Dr. Katherine Palmerola from IVFMD and Claudia Mendoza from Elvis Duran in the morning. So whether you're considering freezing your eggs for future use or curious about the process, you are in the right place. And don't forget, we'll be answering all of your questions at the end, so feel free to submit them anytime during the webinar. Also, following this webinar, our scheduling team will be in touch to schedule your complimentary new patient consultation if you have not already had a consultation with us. Finally, I would like to thank you all for joining today, and I will now let Dr. Palmerola and Claudia introduce themselves. So Dr. Palmerola, please take it away.
Thank you so much, Morgan. It's amazing to be here today. I'm Dr. Katherine Palmerola. I'm one of the fertility physicians at IVFMD in South Florida, Miami. And I'm honored to be here. This is an amazing topic, one of my favorites. I could go on for hours, but I promised Morgan and Claudia that I will keep it short and sweet and to the point. Let me just, now's a good time to share my screen, Morgan, would you say, so we can introduce ourselves?
Yes, absolutely.
Okay. So I'm just going to expand this. Yeah, so welcome to Fertility Preservation 101. I'm going to go through all the details, ins and outs of egg freezing or embryo freezing, answer questions. Please chime in if you have questions along the way. And I'm happy to be here. So I'm Dr. Katherine Palmerola. I actually came from the Northeast. I did my training in New York City at Columbia University for my OB/GYN residency and then REI fellowship. I stayed at Columbia for both. And then I ventured down to Miami, where I've been for the past 6 years. So I'm one of 12 physicians at IVFMD. We have locations all over South Florida. I'm based in Miami, and I see patients who are interested in building their families, patients who are not ready to get pregnant. They're interested in freezing or preserving fertility, or patients who also are experiencing miscarriages. We cover all of that spectrum. Today, we'll obviously be focusing on egg freezing. Claudia, off to you.
Thank you. I'm Claudia Mendoza. I'm the executive producer for Elvis Duran and the Y100.7 morning show here in Miami. And I wanted to tell you a little bit more about why we're doing this. And it's simple enough. I just got married, and my husband and I are trying to, maybe not have babies just yet. We want to enjoy ourselves. But then we thought about different ways to make sure that in the future, when we're ready, we can actually create our little family. So
very smart.
When the opportunity arose, I was like, yes, let's sit down with Dr. P and ask all the questions. So I went in and I asked her all the questions, and I'm sure she's going to answer a lot of them, if not all of them today, because she's very thorough, and the connection she has is amazing. The entire team in the South Miami office is amazing. So if you're thinking of doing that, if you're getting more information, definitely head on over and get all your questions answered. Meet the team. And if you want to get started on the PowerPoint, let's go, Dr. P.
Okay. So there's a variety of reasons why people may decide to preserve fertility, freeze their eggs, freeze embryos. Historically, it was actually an emergency procedure for patients that were recently diagnosed with cancer, or maybe needed a treatment for, say, lupus or rheumatoid arthritis that might affect their egg numbers. If you're going to go through chemotherapy or radiation, this will sometimes induce menopause. So historically, egg freezing emerged really only as an emergency option. However, as our technology for freezing became better, and as insurance companies started to pick up on the fact that and provide coverage for egg freezing, it's become more of a social reasons for freezing eggs. So for example, if we're focused on our career and we know that we have a longer trajectory before we're ready to build our family, egg freezing or embryo freezing is being considered. if you haven't met the right partner, and you don't want to feel pressured into starting a family with someone that you're not ready to start a family with, or starting a family alone, egg freezing or embryo freezing has emerged as an option to really give you time, and possibilities and options. You don't have to feel forced into a partner or a family before you're ready. So it's really, I would say, the large majority of my patients who come to freeze eggs are really, they know they want the option of a family in the future, but they're just not ready yet. So the reason why it's important to think about this, and why I applaud Claudia for even considering this option, knowing, she recently got married and she has a partner, which is amazing, but knowing that she's not ready for family yet, the reason why that's really important is because, unfortunately, our egg number, our egg quality goes down with time. We do not have an infinite fertile window. Back, in centuries past or in generations past, we were getting married or linking up with our partners very early and starting our families very early. And we really didn't see the effects of fertility because we'd completing our family by the time we were in our 30s. Trends these days is that we're not ready to start our family until our 30s or maybe even our 40s. And so, unfortunately, our fertility has not advanced socially with the times, and we're on a tight timeline. So as we get older, unfortunately, our egg number and our egg quality declines. We have many, many measures for egg number, but we unfortunately do not have a direct measure of egg quality. We assume that egg quality goes down because of some of the slides mentioned here. We see as we get older, starting in our mid-30s, it starts to take longer to get pregnant, and we start to see more miscarriages as we get older. The bottom graph here states aneuploidy. Aneuploidy means abnormal embryos, abnormal chromosomes in a pregnancy. This is the single most common cause of a miscarriage. And the graph is a little bit concerning because, yes, we're at a peak fertility in our mid-20s, early 30s, and then slowly, gradually, we start to see a decline in egg quality, which manifests in taking longer to get pregnant, seeing more miscarriages. Very gradual in our early to mid-30s. There's a little change in the slope of that curve as we get to our later 30s. And then by 40, it unfortunately, on average, for most people, it takes off. So this is why we need to be mindful of our fertility. We can't be, yes, we can be career focused and decide to have our family on our own time, but actually we need to be proactive to preserve our best quality eggs to make that a possibility.
Dr. P, and is there like a difference between egg freezing and embryo freezing? Because if we're thinking my husband and we can teamwork, but if I don't have a significant other yet, how can we make
Yes,
that work?
definitely. So egg freezing refers to taking your eggs and freezing them as an egg. Embryos is once we combine an egg with a sperm, and they are very different. So the actual treatment, which we'll get into, is identical, but the end output, an egg versus an embryo, is totally different. We can do both, but depending on circumstances, for example, if you have a partner or not, age and number of eggs, there might be one strategy that's better than the other. So for my young single patients, I typically highly encourage freezing eggs because we'll have good numbers, good quality based on age, and we don't need to be committing to a sperm source. As we get older, because of the concern for quality of egg, quality greatly impacts our outcome. And we need that many more eggs to have confidence that they're going to become a baby if we're at an older age because of the quality. Sometimes based on age, or if we have a low number of eggs, then it does make more sense to form an embryo egg with sperm, whether you have a partner or not, because it will give the egg its best chance of becoming that baby that we're hoping it to be in the future. There's a big dropout in human reproduction, human fertility. Not every egg becomes a baby. The biggest driver of that success, egg to baby, is quality of egg. And the more we have, or the younger we are, the more confident we feel that it will become that baby. So when we have a low egg number or older age and therefore lower quality, it does sometimes make sense to form an embryo because we'll have higher confidence in that embryo moving forward. Does that make sense,
Right.
Claudia?
Yeah, it makes sense. And if any of you have any questions, feel free to leave it in the chat box. It's completely anonymous. We're going to go and answer through them as we go along. And then we have a Q&A at the end as well. So if anything just pops in your head, let us know. We're getting them. And then we'll go ahead and answer throughout the webinar. Thanks, Dr. P.
Yeah, of course. So I mentioned we have many ways to test for egg number and how the ovaries are functioning. And this is part of your initial testing. Before we do egg freezing, we do some testing to find out, is this going to be the right treatment? Will it be successful? What can we expect? So these tests include blood work as well as an ultrasound. On the blood work, we do the cycle day 3 labs, which are done on cycle day 3 of your period. This is, or 2 or 4, but ideally day 2 or 3. This is when your body is at its baseline. And I'm checking hormones that come from the brain and from the ovary to understand how they're communicating. Based on the levels, I get a sense of, oh yes, ovaries are working very well, or ovaries are starting to not work as well. We can also test in the blood a hormone called AMH, or anti-Mullerian hormone. This is a reflection of the underlying egg numbers that your body has. Now, mind you, we have thousands and thousands of eggs. We even have 1,000 eggs when we're in menopause. So we have tons of eggs. AMH is a reflection of that reserve. When we're doing egg freezing, we work, I'll get to that, but AMH reflects on our underlying reserves. It's most closely tied to your age, but also genetics, what you got from mom and dad. This is not a number that we, at this time, really know how to change, how to make better if it's low. It's a number that gives us insight into your body and what types of medications, how much medications we need to use. It is often a source of stress when it comes back lower than desired, but I try to reassure my patients that this gives me information about how we're going to arrange their stimulation. It is not a number that tells us if it's easy or difficult to get pregnant. It is purely developed as a number that will help us with our treatment. The third measure that we do is an ultrasound. And so we have thousands and thousands of eggs, but on ultrasound, we will see the small group that your body works with each month. So naturally, for women who are getting regular periods, you have a small group of eggs. Your body chooses just one to grow. The number that we see on ultrasound is the small group. Again, you have thousands of eggs, but each month you work with a small group. That small group is so important, and in my opinion, often more important than the AMH, because that, what we see in ultrasound, that's what we can expect to, that's what we're aiming to grow during an egg freezing treatment. So we use the combination of these three to get a sense of what are their chances going to be, how many eggs should we be expecting if we pursue treatment, what style of medication should we be using, etc. AMH in general goes down with time. Okay. It's not a number that I like to trend month to month. We really have to give it, at least 3 to 6 months to really see a true trend. And in general, it goes down over time. In contrast, the day 3 labs and the follicles, they can fluctuate month to month. Some months might be better than other months. And so, if we have great testing, perfect. Let's go for it, whichever month is a good time. But if we have, testing that's maybe not perfect, then yes, sometimes it's a balancing act of, okay, this is a good month. We caught your body at a good time. Let's go for it. Or this month doesn't look so good. Let's see if maybe next month is better. It's always going to be a balanced discussion with your doctor. But these are my bread and butter, my favorite tests. They give me lots of information about the ovaries and how to design the stimulation treatment. Okay. So the process involves first chatting with a doctor like myself or one of my colleagues, and we're going to ask you many, many questions about your medical background. You know, yes, we're aiming to freeze eggs for the future, but your current health is very important. If we have certain medical conditions, we want to make sure we optimize that to get our best egg health. There might be certain aspects of your history that make this treatment more dangerous. So we'll ask general questions about your overall health to make sure that we're getting our best quality egg. Roughly, then you'll go through a testing phase where we look at those special hormones, as well as other hormones and blood work that are relevant to your egg health. Depending on where you are on your period, it may be very fast to do this testing, a week if your period's within the week, or we might have to wait and, you know, maybe you just got your period before consultation. So maybe we have to wait a month before we get the rest of this testing. But testing is typically fast. It takes 2 weeks to get your eggs ready. That's it. Okay. It happens to be a little bit intense, but it's only a 2-week commitment. Before that 2 weeks, there will be a prep phase. So depending on your testing, there's certain ways that we prepare the eggs to be stimulated. And so sometimes that involves nothing and we begin on your period. Sometimes we do use a birth control pill to synchronize the eggs. Sometimes we prime with a different type of hormone. It all depends on your testing of how your treatment will be designed. Regardless of how we prime, the actual treatment is roughly 2 weeks. So naturally, your brain releases just a little bit of hormone to grow one egg. But when we're doing egg freezing, I want a whole bunch of eggs to grow. So we give you hormones, same ones as your brain, bioidentical, natural, but more. They are super physiologic amounts of the hormones that you already have in your brain, and that tricks the ovaries into growing many eggs. These are little shots that you're doing yourself in your belly for about 10 to 12 days. So it takes about 10 to 12 days of hormones from your brain to get the eggs ready. During that time, you come into the office a lot. You're coming in every 2 to 3 days. We're monitoring your response, making sure it's working, making adjustments. And that tells us also when are the eggs ready. So I say it's a little bit intense because for 2 weeks, you're doing injections and you're coming into the office all the time. These tend to be very early morning appointments. So it hopefully, depending on your job or what you do, it often doesn't interfere with your work life, with your day-to-day life, because you're coming into the office, you're doing your appointment, and then you're off on your day. It's not going to alter your thinking. You can perform your normal functions. After 10 to 12 days, your eggs are ready, and we do a procedure to get the eggs out. This is done, it's office-based, so it's in the office, but you have sedation. You are asleep for the procedure. You are comfortable. You do not feel pain. It's actually a very nice rest. And it's fast. Yeah. I would say I do have patients that say, oh, my favorite part, bring on the medications. This is my favorite part. It's a very nice, well-deserved rest after this 2-week treatment.
And does it affect if, let's say I'm taking birth control, does it affect what medication I get and the amount in the shot, or is it already helping me? Is it not helping me depending on birth control?
Okay, good question. So birth control, depending on your type of birth control, so for example, an IUD has no impact. That's the intrauterine device, copper or hormonal IUD, doesn't matter. The IUD can stay in place. It's not going to affect this process whatsoever. So we just work around the IUD. Birth control, we often use birth control as part of this process. And so sometimes depending on your testing, we continue the birth control and then we'll tell you to stop it before beginning your medications. If you've been on birth control for a really long time, okay, This can be suppressive. It can actually show as lower egg numbers, lower hormone levels, because it suppresses the ovary function, but it's temporary and reversible. So if you've been on birth control for say 10 to 15, even 20 years, then, I might anticipate, okay, we're going to be a little bit suppressed. So maybe we need to give ourselves a window of coming off of the birth control to see our best egg levels. And I also suggest that if we're a young patient, but we've been on birth control for a very long time and our levels look low, and then we might want to give ourselves a window to recover from the birth control suppression. Hormones can rebound, egg numbers can rebound, and then we begin our treatment. Sometimes the hormone levels are absolutely perfect and fine, and we can just roll straight from your birth control into treatment without stopping.
Okay, perfect. And you said that it wouldn't affect our day-to-day at the beginning, because we're gonna do at the beginning of the day, not throughout the day. But if I mean, obviously giving myself a shot, that's psychologically thinking I have to poke myself with a needle.
Yeah.
And I'm thinking also, what can I do to create the best egg? Or if I have a lower egg count, how can I make more eggs? Can I change my diet, or does it help that, I have to like mentally prepare myself and be emotionally happy for it to like be more
Yeah.
instead of like stressing myself out? Because I'm guessing stress definitely affects this.
This is not ideal. Yes. So definitely there are some general things that can try to help egg quality. So we don't have a direct test of egg quality, but some common sense things will help us. So first of all, if we had any underlying medical conditions like blood pressure or diabetes, we want to optimize those before we go into a treatment. Okay. So if our diabetes is poorly controlled, no, we got to get, this is not an emergency under most circumstances. We have time to optimize and get our best quality egg. So optimize other medical problems. In terms of diet, I would view egg freezing as trying to prepare your body for pregnancy. We're not getting ready for pregnancy now, but I want these eggs ready for when I am pregnant. So in general, I suggest a low inflammatory diet. So low in sugar, low in high glycemic index foods, bread, rice, pasta, dessert, decrease these delicious foods because they can be inflammatory. Try to eliminate processed foods from your life. Inflammatory, okay? Many, many research studies showing that they increase cardiovascular disease, cancer risk. All processed foods are just terrible for us. So trying to cut out processed foods, high glycemic index foods, focusing on high quality protein, high quality fat, high quality carbs. You should have a balanced diet. We can't eliminate a food group, but they should be quality calories. Regular exercise would be ideal. Mix of cardio and weights is good for your metabolism and overall health. Striving to have good sleep habits. Okay, sleep is very closely tied to fertility. And if we are a shift worker bouncing around shifts, no, when it comes time to doing this type of treatment, I would talk to your supervisor, talk to work. You need to be on a steady schedule for this to be successful. Alcohol and drugs. So smoking, vaping, no, just cut that out for your entire life. This is never going to be good for you ever. And it's especially bad for our eggs. Women who vape or smoke, they go into menopause earlier. The egg quality is terrible. And your interactions under anesthesia can be damaging, can be dangerous. So I'm very strict with vaping and smoking. I decline to treat you if you are currently smoking because it is dangerous and it will affect your overall health and egg health. So just eliminate smoking and vaping for your life. Alcohol, we should tone that back. Okay. The WHO, the World Health Organization, recently updated the recommendations for alcohol intake for men and women. And it used to be 1 glass per day. Not anymore. No, any amount of alcohol has been linked to increased risk of many, many health conditions. So during treatments, I highly encourage either no alcohol, the whole time period leading into treatments, I would suggest very minimal light social alcohol, meaning 1 to 2 drinks on weekend only. Marijuana, no. Recreational drug use, no. So all of these, will have danger for your anesthesia risk for procedure, but also can affect the underlying egg health. Marijuana has been linked to miscarriage risk. So all of these, we should be, trying to eliminate risk for this treatment, which is a choice, which is not an emergency, while maximizing the health of your egg. So sometimes you talked about stress as well. Our life is stress. We are constantly surrounded by stress. But if you know you have a big project or a deadline, or if there's a big event that's going to be causing stress, this is not the time to do treatment. Wait until after. Okay. Again, under most circumstances, unless we are egg freezing for cancer treatment, this is a choice, and we can choose when we want to do the treatment for our best outcome.
Okay.
Great question. Yeah, so the treatment culminates in egg retrieval, which is very fast, under anesthesia, 15-minute procedure. It's a vaginal procedure. There's no incisions on the belly. The same day that we get the eggs out, the eggs are frozen later that day, and you then go through about a 2-week recovery period. During this time, ovaries are growing and many eggs are growing. So ovaries get bigger. Normally an ovary is maybe 3 centimeters, and they can double, triple in size during this process. It's going to take a week for them to shrink back down.
Okay.
Hormones can go high during this time. Everybody feels differently with that. Some women feel absolutely no change. Some women can get emotional, irritable from the high hormones. Some women feel really good. Okay. 1/3 of my patients feel awesome on the hormones. After egg retrieval, all the hormones come out of your system, and sometimes that drop in hormones doesn't feel so great. I recommend viewing this as how your typical, if you have mood changes in a typical period cycle, you can expect similar mood changes, maybe heightened.
Okay.
So this is an example of a classic timeline. We have this prep period where we'll have our consultation, we'll do our testing in our labs, and that will tell me what style of medications you'll need. That will tell me exactly how to work your protocol. Once we have your protocol, at least at IVFMD, we'll then start reaching out to insurance and get authorization. Yes, believe it or not, many insurance companies do cover this treatment, which is amazing. So we'll get insurance authorization. We'll prescribe you the medications. We help you with the medications. So our team of nurses connects you with resources and teachings on how to prepare the medications. This is a major source of anxiety for many people, but we help you with that. You'll get a whole bunch of paperwork and consent forms, and then we begin. It is often based around your period, the priming or not priming. We begin this treatment at your baseline when you're on your period. We end up doing approximately 10 to 12 days of injections of the medications. Whether it's 10 days versus 12 days, it depends on your body. Everybody's body is a little bit different. So you're coming in during that time close to every other day or every 3 days. In the beginning, we have a little bit of a break, but then towards the end, sometimes it can be every day because the eggs and the hormones can change that fast as we get towards the end. We'll do the most important part of the stimulation, which is your trigger shot. The trigger shot gets you ready for egg retrieval day. Egg retrieval day will occur 35 to 36 hours after that trigger. So 2 days later. So based on your period timing and your stimulation plan, we'll often be able to give you a window of when we think that egg retrieval will fall, but it could be plus or minus a few days based on how fast or slow your body reacts to the medications. You can be working this entire time during the stimulation, but egg retrieval day is when you need to take off from work because of the anesthesia. depending on egg number, if we have really high egg numbers, you probably want to try to take 2 days off from work. If we have an average or low egg number, you are often ready to go back to work the very next day. So in general, it's not a huge impact on life other than taking these injections and coming into the office. That can be a stressful time.
What's the difference between having a high egg number and why you would need that extra day? Now I'm curious.
Yeah. So if you have high egg number, that means your ovaries are that much bigger and you're that much more swollen and full. And so you may not feel like you're physically ready to go back to work the next day because you're bloated and full.
Gotcha. Okay.
Yeah. So this is a really cool graphic of what the actual procedure is like. It's a vaginal procedure. The entire time we're doing your monitoring, we're using vaginal ultrasounds. And that is our best way to see the ovaries. So this is what it looks like when we look at the ovaries under the ultrasound. These are the follicles which are growing and expanding as a result of the medications. Eggs are microscopic. We can't see the eggs, but based on the sizes of your follicles and the hormone levels, we have an estimate of what we're expecting to get, how many eggs we expect to get, when are the eggs ready. So you're doing these vaginal ultrasounds all along. We use the same vaginal ultrasound for the time of egg retrieval, but it has a little needle. This might be TMI for some patients, but it's actually a really fun, cool procedure, especially for this patient. Her ovary is right next to the vaginal wall. This bright white line, this dotted line, that's actually the needle going through vagina straight into ovary, and that's how we get the eggs out. It's an aspiration procedure. This is another cartoon graphic. So needle goes into the ovary, we aspirate the fluid, the egg is floating around the fluid, and we pass that off to embryology. They're working with us at the time of procedure, counting out the eggs as they find them under the microscope. So we just go one by one into the ovaries, into the follicles within the ovary. Depending on anatomy and possible, I try to do 1 poke per ovary. And sometimes we have to readjust, but it's a tiny, tiny little needle puncture from vagina that goes straight into ovary to get our eggs out. Really cool, in my opinion.
Yeah.
And again, you're sedated, so you're not feeling any of this pain. That's why it's critical to be healthy and not smoking, so that we can safely sedate you for this procedure.
Perfect.
So the ovaries, once we retrieve the ovaries from the eggs, we're working with our embryology team. And that same day, approximately 2 to 3 hours, we vitrify or fast freeze the eggs. This is the latest technology as of the past 20 years. In the past, there was a slow freeze technology, which was damaging to the eggs. This is why it was kind of experimental and only for emergency cancer circumstances. The newer technology for the past 20 years is vitrification, which is like an immediate fast freeze. And eggs are kept at this very, very cold temperature within a liquid nitrogen tank until we're ready to use them. So the vitrification technique has allowed for much better egg survival. We used to quote a very poor unfreezing success of the eggs because of the process. Eggs are this really big cell filled with lots of water. And so the slow freezing allowed for the crystal formation, and then eggs did not tolerate that very well, being warmed up again. In contrast, the vitrification is just like an immediate fast freeze, and they are surviving unfreezing. Excellent. Not 100%. So one of the risks of freezing eggs is that we cannot guarantee that they will all survive unfreezing, but we quote about a 95% survival when we go to unfreeze them because of this better technique. And they can be frozen for decades. The amount of time, whether they're frozen a month or a year or 5 years or 10 years or 20 years, it does not change their success, which is really cool. So your egg number, egg quality are literally frozen in time, waiting for you. If you were 33 when you froze your eggs, and now you're 53, you have as long as you're a healthy 53-year-old, you will have the healthy pregnancy of a 33-year-old, which is so cool.
And if I do freeze my eggs, right? And I want to, do I have to do IVF? Or maybe in between that time, I got pregnant and maybe I don't need to use those those embryos or those eggs. How do I go on about using?
Yeah. Okay. So really good question, Claudia. I view frozen eggs, and I counsel my patients, these should be your plan C. This is your backup plan. Okay. So when you're ready to start your family, if possible, it's best to try naturally. Okay. Now, if you're in a same-sex relationship, or if you're a single parent by choice, obviously it might not be, or if your partner has had a vasectomy or has no sperm, then, maybe trying naturally is not going to be an option for you. But if it's possible to try naturally, you should try naturally. If pregnancy is not occurring naturally, then you should seek a fertility provider, do an evaluation for you and your partner, and consider treatments with your eggs at that time, even if you're older. Okay. And the reason is that we have a finite number of eggs and they go down with time. So going back to those original slides, our fertility window is small. Okay. And we've had our frozen eggs. Those are not going to change. We don't have to stress about using those fast, but if we can get more eggs from your body, we should, because we're not always going to be able to do that. And so if we can get more eggs, we should do a treatment at that time. Now, sometimes those treatments are not successful, or sometimes your testing is not good, or we're that much older and we have so few eggs and poor quality that it might not make sense to do treatment. That's when we go to these eggs. Okay. Or maybe we are 100% certain that we only want one child. Okay. Maybe it makes sense in that circumstance to use our frozen eggs from a younger age, before trying naturally or before doing new treatments. So you do not always, I suggest not using these eggs because they're not going to change. There's no rush. And if once we use them, then they're gone. Okay. We may not have the ability to get more in the future. If we decide to use the frozen eggs, yes, it does involve working with a fertility center and doing, an IVF style treatment. Okay. Egg freezing is like the first half of IVF, but then we have to form embryos and implant. And that's the second half of IVF. And so it requires working with a lab, and a fertility doctor to be monitoring you, making sure everything is okay. It does not have to be the same center where you froze your eggs. So maybe we freeze eggs in Miami, but then we move to Seattle. Your eggs can move to Seattle. Each center has their own policies. So it is true, some centers don't accept eggs from outside centers. You just want to check with their policies, and you do not necessarily have to return to the location where you froze the eggs. What?
Info.
So we already talked about this a little bit, but they can be kept frozen storage for decades. There was some news articles a couple of years ago about an embryo that had been frozen for 27 years and resulted in a baby, and then a sibling that was frozen for 25 years. So the duration of time does not change the quality of the egg. That's pretty cool. They're literally frozen in time. Age is critical. It's the most critical determinant of the quality of the egg, which we have no direct test for, but based on observing millions and millions of women, we do see that it takes longer to get pregnant, and we see more miscarriages as we pass our mid-30s. And so therefore the quality is assumed to be affected. So your age, when you decide to pursue this treatment, really helps us understand your testing, how many eggs. It's a combination of the two. We'll have an understanding of, okay, this will be an excellent treatment. We should do this one time and you should be set. Or if we have a lower egg number, maybe we need to be planning to do this a couple of times in order to get the numbers that are sufficient to feel confident in this backup plan. Okay. Unfortunately, we need a high number of eggs to best ensure that they will become a baby, because not every egg makes it. Not every egg unfreezes. Not every egg fertilizes. Not every fertilized egg becomes an embryo. Not every embryo becomes a baby. So the more we start with, the more confident we feel that we're going to get to that endpoint. If we have a very low number to start with, okay, maybe we need to plan to do this a couple of times. Or maybe we decide instead of making eggs, freezing eggs, maybe that helps us with the decision of forming embryos, okay? As we get older, we need that much more eggs to become a baby because of the quality dropping and higher chances of abnormal embryos. So it's a balance based on your age and your testing and your circumstances. Do we have a partner? Do we not? Whether we freeze eggs versus embryos to kind of maximize our chances.
And let's say I'm 20 something and I freeze my eggs. I still don't have a partner. 5-6 years pass, found my partner. We're thinking maybe kids, but later. Can we convert those frozen eggs into embryos, or do we have to do a whole thing again of freezing eggs and to make sure that they become embryos and then freeze them?
Yeah, you can make eggs into embryos and then keep embryos frozen, of course. You know, depending on how many eggs, your reserve right now, your desired family size, it may make sense to do that. It may make more sense to make more embryos. Maybe we want a large family size, and rather than spending resources on making our eggs into embryos, maybe we make more embryos because of large family size. So it's really, you know, every circumstance is unique and different, and depending on goals, comfort as a couple in having embryos versus eggs, age, egg number, all of this kind of guides our recommendations and decision-making of what treatment option is better for you. I have some patients that decide to do both. They know they want eggs as an option, but they also know, you know, as they're getting older, that we feel more confident in embryos. So I do have patients that decide to do both to kind of divert, not have all eggs in one basket. So success, you know, there's many different calculators that we have available to give us a gauge of success. And unfortunately, because of the dropout that occurs and our lack of a direct test for egg quality, these are all estimates, okay? In contrast, when we have an embryo, we have great data and statistics on embryos, and we can say with confidence, this embryo is going to, based on testing and everything, where we have this percentage chance of a baby. Eggs are different, okay? And we don't know with certainty how they will perform until we go to use them. So we have general estimates. And obviously, the more eggs we have at the younger age, the more confident we feel. One of my favorite calculators comes from the data at NYU. NYU in New York City, they've been freezing eggs for the longest. They were one of the earliest developers of the technology. So they had women coming to freeze their eggs at the beginning of this technology. So now they have many patients that have actually come back to use their eggs, and they have been excellent about sharing and compiling their data. So they have this wonderful table based on age and how many eggs, fresh eggs versus frozen eggs, we need on average, general estimate, to form an embryo. So I reference this data all the time. And if we're younger than 30, quite young in our 20s, we need very few eggs to get there. And fresh versus frozen, they have very similar outcomes. But as we get older, you'll see we start to need more and more. The numbers are different between fresh and frozen because not every egg that is frozen may survive unfreezing. So we kind of need to bank or plan on having a little bit more because they may not survive the unfreezing process. And then as you see, once we get into our 40s, we start to need a really high number of eggs in order to try to guarantee an embryo. So I reference this table all the time before treatment with my patients to kind of gauge expectations. Should we be planning on one cycle, or do we need to mentally prepare for multiple? And then after the fact, okay, you're this age, we had this many, how many embryos on estimate do we need? So it's helpful for expectations going into treatment. I think it's really critical to know that this unfortunately is not a guarantee for baby. That's one of the biggest risks and limitations of this treatment is it is by no means a guarantee. It's the best we have today. Hopefully more better technologies emerge as we advance science.
Yeah.
But we have general estimates to give us a sense and confidence. Do we feel high confidence, so confidence, very low confidence in this treatment that we just did? So a little bit on the process of what to do when we've made the decision that yes, we're going to be using our eggs. You'll again be working with a fertility doctor. It does not necessarily have to be the same location where you froze your eggs. You would be doing an evaluation, if applicable, of the sperm source of your partner, making sure we have good sperm for these perfect eggs that we froze a while ago. The focus when we're ready to use the eggs is going to be pregnancy. And so we have to do an evaluation of the uterus and make sure there's no structural or inflammatory barriers that would prevent an embryo from sticking. We'll evaluate your hormone status and your blood work to make sure that body is optimized. All of our underlying medical conditions should be optimized. And once we're ready, you would go through a preparation to get the uterus synchronized with the embryos. Eggs would be unfrozen, combined with sperm, developed into an embryo over the span of about a week. And then the embryo, we have a couple of options. We can be placing an embryo directly into your uterus for pregnancy. We can genetically test the embryo to know its genetics and then proceed with implantation. Genetic testing of your embryos, it's again going to be a decision based on circumstance and goals and testing. Sometimes that makes sense to do. Sometimes we actually shouldn't genetically test the embryos and we should just place them inside. Embryo transfer is a very special procedure. And it's a procedure where we delicately place the embryo into your uterus for pregnancy. It shouldn't be a painful procedure. It should be very gentle and comfortable. We're watching with an ultrasound. You're awake for this procedure. And it's the culmination of all of your hard work and efforts. So it's one of my favorite days. And so the other question I get a lot is, what if I never need to use these eggs? What do I do? Even before you go through this process, we're actually going to ask you this question. And on your consent forms, you're going to tell us what you want us to do. I mentioned that because, we have a tendency to we have signature fatigue and we just sign. But this is a really important one because we do actually ask you, what do you want us to do with your eggs in the event that you become incapacitated or if we are unable to reach you, okay? And there's generally 3 options of what we do with the eggs. They can be medically discarded. We can donate them anonymously to other patients, other couples. They can be donated to science for research so we can better understand human reproduction and hopefully try to improve our success. If the eggs are donated to another couple, this is an anonymous donation. They will never know your identity, but they do get general background information about your ethnic background, appearance, testing, age, things like that, but they would never know your identity. So we generally have we can anonymously donate to a couple, or actually we could designate a person to have our eggs. So for example, if you have a partner, you can designate these eggs to go to your partner. If you do not have a partner, you might designate these eggs to go to a sister or a parent, for example. So they can be donated to a specific person or anonymously to other patients.
And it's just for the eggs or also for the embryos?
Also for embryos.
Okay,
yeah.
cool.
So the same questions exist on the forms for the embryos. And so it's something that you might change your mind. So you might have one thought before treatment, but as maybe a year goes by and you decide, no, I want to change what I do, we can always update consent forms. Okay. And then another piece of reassurance is that we will never discard of your embryos without your permission. Okay. Unless there's been extenuous attempts to contact you, not one missed email, but email, phone, a physical piece of mail going to your, so there has to be multiple attempts at contact before eggs or embryos are discarded over a prolonged period of time. But it's important to keep in mind, these eggs will be going to a storage facility. At least at IVFMD, we do not keep the eggs on site long term. They are moved to a storage facility. You're going to have a profile and account set up with the long-term storage facility. Make sure your contact information is up to date in the event that they need to reach you. So if you change your phone number, if you change your address, if you change your email, please remember to notify the storage facility. Personally, I have never had patients who have inadvertently had their eggs discarded, but of course you hear horror stories on the internet about cases of eggs being discarded. So just keep in mind, you're going to have an account with the storage facility. Make sure your contact information is up to date so that they have the ability to contact you if needed.
Perfect. We have a few questions, Dr. P. One of them, are there any risks involved in fertility preservation?
So the risks, there's always risks. The majority of the risks relate to symptoms. So you're going to have bloating. You're going to feel full. Normally you grow one egg. Now I'm going to try to grow multiple eggs. So you will feel symptoms of bloating and pressure. Women who have many eggs, we do have a risk of something called overstimulation, which feels like extra bloating and pressure. So it's normal to have symptoms and mild discomfort during this process because of the bloating. We have always risks from procedures. There's always a risk to anesthesia. And that's why making sure we're doing this under safe circumstances is so critical. We have a very small risk of infection. We treat with antibiotics. I would say major infections are extremely rare. Very small risk of bleeding. Major bleeding is extremely rare. The biggest risk I counsel my patients is that this does not guarantee a baby. And it is possible that you go through this treatment and it is possible that the eggs will not become a baby. I would say that is the highest risk.
Okay. Yeah, sorry.
Oh, it's okay. I am not
then,
accelerating menopause by getting many eggs out. Okay. You had a group of eggs that your body naturally grows one. I'm using my medications to grow the whole group. So I'm not going to be accelerating menopause by, 13 months if we get 13 eggs.
Gotcha. All right. Another question is, my partner and I are looking into surrogacy. Does your facility provide this, or can we provide them any resources about this?
Yeah. So surrogacy is often a treatment that's possible through many fertility centers. At IVFMD, we have an entire team dedicated to that process. So absolutely, we would assist you. There's many surrogacy agencies. It's a very complicated process. So I would work with a reputable fertility center that has the knowledge and can help you smoothly through that process. So absolutely, we do that at IVFMD.
Perfect. Can you do acupuncture treatment through this process? I know a lot of people do a lot of holistic and different things to help them get to that point. So can we use that?
I love acupuncture. It's a great adjunct, at a minimum, relaxing, anxiety relieving. So I love acupuncture. I ask that my patients share the fact that they're going through this treatment with their provider. Maybe there's different points that we need to avoid. And then no acupuncture herbs during treatment, because sometimes that can interfere with our medications. But I love acupuncture. I encourage it during treatment if it's something that you enjoy.
Oh, perfect. And another one is this is an IVF question. Should I consider IVF after 6 IUIs?
Definitely. I mean, so it depends on the exact circumstances and what's going on, but I like to regroup with my patients after 2 cycles of not being successful. Okay. Maybe there's things that we need to tweak or adjust or optimize. After 3 to 4 IUI treatments, our chances of success start to like plateau. And that's when we really should start considering moving on to another treatment like IVF. Now, maybe IVF is not an option based on testing or age or other factors, but I typically encourage my patients to move on to a treatment like IVF if that's possible, if we're not successful from 3 or 4 treatments of IUI.
Perfect. So far, those are the questions we have, and looks like we're running great on time. If anybody has any more questions or anything that you want Dr. P to dive into a little bit more, I feel like it was very informative. All the graphs and everything just really helps paint that picture visually. I'm a visual person, so
Yeah.
just being able to see that and just get it's definitely helpful.
It's a lot of information. It's one of my favorite topics because it's so empowering. I would say the large majority, if not all of my patients who, after completing this treatment, they feel relief. This was a big treatment. They feel proud of themselves for devoting the time. There's never going to be a good time in life to do this treatment, there's not going to be a good time. And so my patients after treatment, they feel relief and empowered, and it's really awesome to see.
We're able to, I don't see any more questions coming in, but I'm glad we were able to answer all these questions within time. And as you can see on the screen, if you guys have any more questions, you can head on over to email at IVFMD@IVFMD.com or dial that phone number. Dr. P is located in the South Miami office. The entire team, like I said at the beginning, is amazing. From the moment you walk in, you just feel welcomed. You feel like you're there safely to, get all your questions answered. So someone from the IVF team is going to reach out to you with the free consultation. I don't know, Morgan, if you might have a little bit more info on that, but
what an honor to be here tonight, sharing my favorite topic. Thank you for hosting this, Claudia and Morgan.
Thank you for joining us, for sure. Very, very informative, Dr. P.
Definitely. Thank you all. Thank you guys so much for joining. And yes, like Claudia said, if you guys have any additional questions, please email us at IVFMD@IVFMD.com. And we'll be sure, our scheduling team will be sure to be reaching out to you guys to schedule that consultation. Have a great night, everybody.
Have a good night.
Have a good night. Thanks, guys.